Welcome back to another edition of the Hart2Heart Podcast. And my guest today is Dr. Amy B. Killen. I'm super excited to have her on the show today. She's very much into peptides, very much into hormones, all the kind of latest and greatest in medicine. But she's also an ER doctor who's now focused more on hormone optimization. So, Dr. Amy, welcome to the show.
Thank you. We're happy to be here.
Yeah. So like I said, I'm super excited to talk about it for, so many different reasons, but maybe we'll just kind of, start with getting to know you a little bit better. So we know that you were an ER doctor. Now you're kind of focused on, medicine that's, completely different than ER medicine. And so how did that transition for you come about?
So about 12 or so years ago, I was an ER doctor and I've been working for about 10 years in the ER in Austin. And I had 3 kids within 2 years. So I had twins and I had one more within 3 years and within 2 years. And my husband had moved out of state for a job. So I was like a solo doctor for all, solo provider for all these little kids. And I had to be up at 3 in the morning to go to work. So I was getting up at 3 in the morning, working at 4, taking care of 3 kids by myself. Basically, long story short, I was getting pretty burnt out, high stress, wasn't sleeping, wasn't exercising, was eating garbage, and kind of getting into my rope. And I remember one day, I was in the ER and I looked out at like the waiting room of all these patients waiting to come see me for, they're mostly chronic medical problems. And I had this realization that if I didn't get my act together, I was going to be those people in 5 years. I was going to be in an ER waiting to get seen for whatever my chronic problem was that I could have taken care of if I had the education and the momentum to do so. So I made the change then.
I saw you say that on a podcast recently. So after you kind of notice that, I guess, what were the changes that you decided to make, and what was sort of like the final breaking point? It just was like, hey, I'm feeling too overwhelmed here. I got to make a change. And
yeah, I really tried to just work on my own lifestyle. I was still happy. I still had to be up at 3 in the morning. I was still super stressed. So even if I tried to make meals at home or whatever, I felt like if I wasn't sleeping well, which I wasn't sleeping more than a few hours a night, that I wasn't able to make all the other things work. So I eventually decided that for me personally, I needed to leave that job and get a job that allowed me some more flexibility. And also, I was just also very interested in learning about all the things that we never learned about. I didn't know anything about hormones. I didn't know, peptides weren't even a thing. This was, of course, a while ago, but I realized there was so much in medicine that I had never been taught. So I got excited about that. And then after a few years of kind of juggling both, I just decided to leave the ER completely.
Awesome. And then, so, I think a lot of people in medicine do have that story. Like, they, unfortunately, I know I just said awesome then, but like, I think it's awesome that you made the change. Not awesome that all those bad things happened.
Correct.
But I think that there's a lot of people in medicine who are, in a similar boat, and some people, for whatever reason, don't make the kind of change. But I think there are a lot of doctors out there that are. And so, in terms of the changes that you made, it seems like the thing that you really want to focus on most was sleep. Is that sort of, and that makes sense, because we all know that's like the cornerstone of health, and I heard, actor and Dr. Andrew Huberman say one day, or maybe he tweeted it out, I don't know if he said like, when you're asking someone like, how are you sleeping? You're basically asking them like, how are you doing?
Right.
And, there's a lot of truth to that, so, you just felt like, hey, like sleep is a thing that I'm going to focus on first. Is that right?
I mean, it kind of came about in a roundabout way. It was funny. After my third baby, I decided to go to see a personal trainer because I was feeling a little like overweight and just wanted to get in shape, and I'm going to, work really hard and get in shape. And I was only like a month or so. What?
You don't look like that now.
Well, thank you. So I only had, the babies were like a month old, the youngest one. So I go to this trainer, and I'm at this random person from Gold's Gym. I just signed up for like 70 sessions, and this woman who I didn't even know. And so I'm going to see her like every couple, twice a week. And at one point I came in and she was like, Amy, you look exhausted. Like your eyes are, your dark circles, and you look wrung out. And like, how much are you sleeping? And I was like, I don't know, like 3 hours a day. And she was like, you need to go home and sleep and come back to me when you're sleeping, because nothing we do here at the gym is going to move the needle at all if you're not sleeping. And it was actually, she was totally right. Like I could, she actually said, don't pay me, go sleep and come back in a few months when we can actually start to build muscle and help you get better. So I think that, several things like that happen where I realized that, I can power through a lot of things. And I did for years, but really, if you want to get healthier, this whole idea, like the hustle culture, got to just work, 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 not sleep, etc. Like that's just so counterproductive.
Yeah, I agree. And I mean, unfortunately, there are times in life where, you do have to basically at some times like, suck it up and do it. But, we go through seasons in our life, just like there's seasons, in the weather. And I think that for the most part, we should really try to live a balanced life. It's good to know that, if we have to, really crush it out for 2 weeks or, a month, like, we can do that. But the goal should be to always live more of a balanced lifestyle overall, and I even heard like Dr. Peter Attia say recently on some podcasts, he said like, I don't even know how to go back to do residency just for 1 month. Like, I don't know how hard, like, it's crazy, like how hard I work then. And like, yeah, like it just like, even myself, like I think it only happened to me a couple times, but there was 2 times, it may have happened to you more often than this, where I clocked over 100 hours in a week, which is just insane.
It is.
And so, yeah, I think that, I mean, it's hard to say that like residency is not effective when you work those hours. It is, but at the same time too, you want a healthy doctor who's not, overwhelmed, burnt out, and that kind of thing. So,
Yeah.
I'm glad that there's, doctors out there like you who are talking about this. So, doctors can not only be not so that patients not only get healthy, but also doctors.
Yeah. I think it's one thing if you're, 30 years, 25, 30 years old to go, a couple of years without sleeping all that much. But I think it's a whole different thing if you're 40 years old or 45 years old, or, as we get older, I do think it becomes more important to prioritize sleep.
I agree 100%. And some of that, we won't get into too much. Just some of that probably even has to do with like, sleep architecture as we, get a little bit older. Unfortunately, we get a little bit, harder to get into REM and deep sleep. Okay. So in terms of, I want to chat with you about hormones today and about your practice. And, you obviously have a lot of experience doing this. And so, let's focus first or mostly on females today. So when should a female get her hormones checked? Like, is there a specific age that you think, or is it mostly based upon symptoms, or what's your sort of overall approach?
It's kind of a tricky question. I think that people should be seeing a doctor and getting, full labs at least once a year, preferably twice a year or even more. And that includes your hormones, including obviously your insulin and your testosterone. Estrogen and progesterone it's not that important to check in women until like sort of late perimenopause because they do go up and down so much. Sometimes it's useful, oftentimes it's not, depending on kind of what your problem or concern is. But certainly you want to be checking all the other hormones that are out there, cortisol, insulin, testosterone, et cetera. And I think that's starting at just as an adult. But perimenopause can start as early as 35 and still be considered normal. And of course, there's also people who are not normal, who are abnormal, who have it even earlier. So I think at least having a relationship with a physician who is watching for signs of that, whether it's, in your labs or more commonly in symptoms, starting at around 35.
Okay. And so what would some of those symptoms be?
So perimenopause, generally we start to see progesterone starting to go down relative to estrogen. So the first symptoms are things like difficulty sleeping, increased anxiety, increased headaches, increased PMS symptoms. So all of a sudden, like you're having like raging PMS symptoms. Those are some of the most common things. You can get all kinds of other things. So you can get hot flashes, you can get, joint pain, things like that. But the early perimenopause symptoms are usually low progesterone. And then later on, you have both low progesterone and estrogen. So you get a whole slew of other symptoms that come on board.
Okay. So if you are someone who is, say, struggling with some of those symptoms, you're a 35-year-old woman, maybe you're 40 years old, and then you draw their labs, for the most part, after you draw their labs, is it still that you would only prescribe progesterone to, say, most perimenopausal patients, or do you also prescribe estrogen to perimenopausal patients as well?
That's a great question. So usually in early perimenopause, we're just prescribing progesterone. And by the way, we can use progesterone even if you're, in your 20s or early 30s and you just have like a lot of PMS symptoms. A lot of PMS symptoms are due to low progesterone. You're just not making enough progesterone, like polycystic ovarian syndrome, but all kinds of other problems that can be. So progesterone is super safe, it's super easy, and you can just take it for a week or two before your period. And that can really help to kind of normalize, your sleep, your anxiety, your headaches, et cetera. And then we usually do that cyclically in perimenopause. So we're giving it to you like 2 weeks out of your cycle, right? The 2 weeks before your period. And then toward the end of perimenopause, when you start having low estrogen symptoms also, so like all of a sudden you're like having joint aches and your whole body feels like you ran a marathon every single day, but you didn't. Night sweats, hot flashes, extra belly weight gain. There's all kinds of dry skin, dry eyes. Like there's a whole ton of symptoms, but those are usually low estrogen symptoms that starts, toward like closer to menopause. So closer to like 40, 45, 50, somewhere in there. Then we'll add estrogen as well.
Okay, so that means if a girl is just experiencing, say, PMS symptoms, we're not really, talking about even, menopause symptoms right now. So obviously girls can get PMS in their 20s, like you had just mentioned, prescribing progesterone, say on days like 15 to 25. Is that more or less like your one of your approaches to treating someone who has PMS?
Yeah, PMS. And we always want to rule out polycystic ovarian syndrome, which is very underdiagnosed. Only about 10% of women who have that are diagnosed. And the problem with PCOS is that we think of it as an ovary problem because it's polycystic ovarian syndrome, but it's kind of a misnomer. Really, it's a problem with androgen excess and insulin resistance. And so if we don't treat that with progesterone, and then also with something to help with your insulin resistance like metformin or GLP-1s or nutraceuticals, then you're setting this person up for heart disease as well as multiple kinds of cancers, uterine cancer, breast cancer, things like that. So that population you got to diagnose as well. But progesterone is easy to get to everyone. I also consider testosterone certainly in women, and that can be in perimenopause, but it can also be in younger women who are, for instance, taking like birth control pills, because we know that in birth control pills, you're going to generally have a lower free testosterone because it gets bound up in your SHBG, which is a transport hormone. So a lot of women who take birth control pills as they get a little older start to have like low libido and fat gain, and they can't build muscle and they have low motivation. And that's because of low testosterone, partially because of their birth control, but also because they're getting older.
Okay. Yeah. And I do want to talk to you about the birth control pill as well. Maybe we'll just come back to PMS just for a second, because I don't think we actually defined it. And so what are the symptoms that, women usually get when they are experiencing PMS, and who would qualify, for the progesterone 15 to 25 day treatment?
It's a wide range of symptoms. Very common. You can get like really bad pelvic pain. You can get sore breasts. You can get irritability, moodiness, anxiety, brain fog. Some women, it's pretty debilitating. Like they're in bed and it's really severe. Some women, it's not super severe. But a lot of those women, and not all respond to progesterone, but a lot of them do, where if you just do a low dose progesterone, 100 milligrams before bed, it helps you sleep. Your anxiety goes better, it calms you down, and it can make that transition into the next part of your cycle a lot easier. Okay.
And so just so people understand too, the difference between, PMS and also perimenopause, because we're using, a similar treatment in both. So the PMS, again, is just related to the symptoms that you just discussed. But for perimenopause, then we're looking at really like a deficiency in progesterone, not just on days 15 to 25, but it would be basically continuously throughout the entire cycle. Is that correct?
So do we see it mostly during that luteal phase, which is the day, 14 to 28 or so, because in a normal cycle, that's when your progesterone goes up really high. So your progesterone is pretty low the first half of your cycle. And then when you ovulate, you get this big, peak of progesterone that lasts about 2 weeks before your next cycle. And then the drop in your progesterone is what causes you to then have a menstrual cycle. So it's, basically what happens during perimenopause is your eggs, we start to run out of eggs, right? That's like your women are running out of eggs, and the eggs themselves, the cells around your eggs, are what makes progesterone. And so because you're not ovulating regularly, you don't have as many eggs, then we start to see that drop in progesterone. But we see it mostly in that second half of the cycle, in both PMS and in perimenopause.
So in perimenopausal women, though, you'd still just prescribe it on days like 14 to 28 or 15 to 25 in the second half of the cycle. Is that correct?
You can do it every day if that person finds it's really helpful, and they're just like, oh my gosh, I'm sleeping so good on this. What I usually will do is I'll still cycle it. So I'll do a smaller amount, like maybe 100 milligrams a night during the follicular phase. So days 1 to 14. And then I'll do a higher dose during the second half, during the luteal phase. So days 14 to 28, I'll do maybe 200 milligrams. So you're still kind of you're trying to replicate what progesterone does during a normal cycle, whether you're, giving it every day or you're just doing a different dosing.
Okay. And so with regards to, the dosing that people are going to use, again, it's more or less if you are perimenopausal, usually it'll be just days 14 to 28. But for some people, they may need a lower dose during the first half and then a higher dose during the second half.
Exactly.
Perfect. And then regards to the type of progesterone, so we know that there's capsules. We also know that there's creams. And I know you did a really good video too on, how to apply your cream. And I do want to chat with you about that. But do you have a preference for progesterone, whether it's capsules or whether it's topical?
Yeah, my preference is oral, so capsules. In perimenopause, it doesn't matter as much as it does in menopause, because in perimenopause, you're making your own progesterone also. The problem with progesterone creams, and this is unique to progesterone, it's not the same with every other hormone, is that it doesn't actually show up well in your blood. And so blood tests will not show progesterone very well if you're applying it as a cream. And that means it's not going to protect your uterus very well from the effects of estrogen. So again, in perimenopause, women will use like creams and that's totally fine. It's just a symptom thing. But once you get to menopause, when you aren't making your own progesterone, if you are taking estrogen, you have to combat the estrogen with progesterone, or you can get your uterus, you can be prone to uterine cancer because the uterus will start to proliferate, kind of build up the inner lining. And so you need the progesterone and you need it to be oral in most cases for that in that phase.
Interesting. Okay. So I think that's a good summary of how to use progesterone. So for the PMS, it's again mostly on days 14 to 28, 15 to 25, and then if we're looking at perimenopausal patients, we know it could be low dose in the first half, a little bit higher dose in the second half, and then overall your approach is to use oral medicine for someone who's in menopause, but if they're in perimenopause or if they're having PMS symptoms, you're using topical creams.
You can. I don't like creams as much in general, but some people do. It's totally fine. It's and there are other forms. They're troches, sublingual.
So you do use capsules
I'll use capsules for everyone.
For everyone. Okay.
There are some women who the capsules make them really sleepy, like super drowsy, and they can't wake up in the morning very well. And so for that small population, we usually will look at doing like a troche, like under the tongue, where it's like a sublingual, or we can do intravaginal, or you can do creams as long as you know that you aren't really protecting the uterus with that.
Okay, excellent. So we talked about progesterone quite a bit. I'm sure we will come back to it, but let's talk about estrogen. So, a lot of people are unaware that there's 3 different estrogen hormones. So maybe that's somewhere where you could start. And what's your approach when you're ordering blood work? Do you order all 3 of these hormones? Do you not order all 3 of these hormones? And then maybe we'll get into after that, when you do replace estrogen, and what ratio do you use? Is it E2 only? Is it E2, E3? But maybe first, I'm getting a little bit ahead of myself. Let's just talk about E1 and E2 and E3.
Yeah. So there are 3 hormones, like you said, 3 main ones. So E1 is estrone. That one is primarily made in postmenopausal women and or from your fat. So estrogen, that's kind of a estrogen made from adipose tissue that, it's been aromatized and you get this estrone. It's kind of classically thought as being a more inflammatory estrogen. Whether that's true or not, I could probably debate you, but that's primarily a postmenopausal estrogen. Or if you're overweight, you make estrone as well. The most common and most important estrogen is estradiol, and that's called E2. And that is the one that, that you make throughout your life. That's the one that really it's causing all the positive effects of estrogen in the brain, in the blood vessels, in the pelvic floor, everywhere. So that's the most important one. And that's the one we want to replace primarily in menopause as well. And then the third one is estriol, which is E3. And that is primarily made during pregnancy. It is a much weaker estrogen. Both E2 and E3 are a lot weaker. Are a lot weaker than estradiol. So estradiol is strong. Estrone and estriol are pretty weak. It's interesting. Estriol, some doctors in the functional medicine space, and I've done training in like the integrative functional medicine space, as well as the traditional medicine space, as well as I've done a lot of different training courses. And I tend to think that when you replace estrogen, just replacing estradiol is fine. Like you don't need to necessarily give estriol. Estriol is about 100 times weaker than estradiol. And so to me, it doesn't make any sense to add something that's that weak into the mix when we really want the positive beneficial effects of estradiol. So I just replace with straight E2.
Do you think there's any benefit, though, of adding E3 in terms of reducing incidence of breast cancer? Is there any evidence for that? Or
There's no actual evidence for that. A lot of functional medicine doctors do like to do that. They like to do what's called biased, which is E3 and E2 combined. And the idea being that they think because the E3 is such a weak estrogen, it's helping to protect against the effects from the stronger estrogen. But my belief is that you want that stronger estrogen. We know from at least from the randomized controlled trials that have been done, there's about 10 of them at this point, have actually shown that women who take estrogen, as long as you don't use that sort of evil progestin, which is the synthetic progestin, you actually have a reduced risk of breast cancer taking estrogen therapy. So estrogen is not evil. And I think that there's no real good evidence that adding E3 does any good. I don't think it hurts. It's fine if you want to do it. We don't really have solid evidence that it helps.
what are, like, when you go to these conferences and you hear these other docs talk about like E3, like I know you kind of mentioned it a little bit just then, but like, what are the specifics? Like, what do they say? Like, why are they prescribing it, and what do they say are like the benefits?
So my initial training was through the American Academy of Anti-Aging Medicine, which is a very, it's a functional medicine kind of group. And the training that they taught that because E3 binds so loosely to the estrogen receptor, because it's such a weak estrogen, that they thought it was better than having E2, kind of helping to break up the E2 binding to the receptor. But the problem is if you have a vial that has both E3 and E2, E2 is estradiol. If you have a vial with both of these things, and estradiol is binding the receptor 100 times stronger than estriol, then there's never really a competition, right? Like
Right.
your body is going to bind estradiol. So what people do is they'll put 80% estriol and just 20% estradiol into a formulation, like a cream, and say, we'll do it that way. We'll try to like ship the curve a little bit so it's binding E3. The point is there's not actually any good evidence in humans that this is necessarily more helpful than just using E2. So what I do is, if someone comes in on bias and they're happy, that's totally fine. But the dose I really care about is how much estradiol are you getting? And the lab I really care about is what is your serum estradiol level? So I also I don't like to do urine or salivary labs for hormones, which is something I used to do. I trained in that, I did that for years. But really all of the studies that we have, all of the solid evidence we have, where we know about the protective effect of these hormones are on serum labs, so blood labs. And so I kind of went back years ago to just doing serum labs for most people. So that's something else that I do. It's a little different than some of the other functional medicine doctors.
Okay. And then with regards to E2, that's something that obviously, you said you start only when someone is in either late perimenopause or menopause. And so for that, you also said that you are using topicals. You're not using any orals for that. Is that correct?
No. So I use both. I use both transdermals and orals. And again, this is something where a lot of doctors disagree with me on this. I always use bioidentical. I never use the synthetic versions. That is important.
Can you explain that? That's something that I
Yeah.
wanted to ask you about. And I know you had a video that you did on that recently. We'll come back to the estrogen, obviously, but I think that's an important point that a lot of people would like to know about. So the difference between synthetic and bioidentical.
So bioidentical just means it's bioidentical, or some doctors call it body identical. It's the same thing. It just means that the chemical structure of the drug we're giving you is exactly the same as the chemical structure of what your body makes. So the estradiol your body makes, if we give you estradiol, it's bioidentical. It's the same chemical structure. When we say synthetic, it's kind of a weird word, but basically that just means that that structure has been modified in some way, and it's different than the structure of the estrogens that your body makes. So, for instance, the Women's Health Initiative, which is the big study that scared all the women and stopped them from taking hormones, they used something called Premarin, which was it's a conjugated equine estrogen. It's made of like 10 different estrogens, like an estrogen slurry, and most of them are not bioidentical. And so some of the downsides that we saw in that study were because it was a synthetic estrogen. They also use a synthetic progesterone or progestin, And that was a really kind of evil beast that actually was the reason that they saw an increased breast cancer risk. It increases your blood cancer, your blood clot risk. So the point being, with hormones, you really want to look for a bioidentical or body identical hormone. But you can get that from a pharmaceutical company, like a just regular pharmacy, or a compounding pharmacy. They both do it, but that's a key importance.
Okay. And then so what you want to do is you want to make sure, like you said, that it's bioidentical to your body. So how would someone know that? Like, how would someone verify that information, whether it's topical or whether it's oral?
It's all in the name. So if you look at the label or the prescription and it says estradiol and that's it, it's bioidentical. If it has estradiol, it has other words in front of it or behind it, it's not. So for instance, and same thing with progesterone. So progesterone just by itself is what you want. It is confusing though, because the synthetic progesterone that they used in the DHEA that's still used is called medroxyprogesterone acetate. So it has the name progesterone in it, and people think it's progesterone, but it's actually this kind of evil twin of progesterone. But so just plain old estradiol and plain old progesterone is what you need to look for.
Okay. So when you're looking for estrogen, just estradiol. When you're looking for progesterone, just progesterone. Keep it simple.
Yep.
Okay. And then just coming back to the oral for the estrogen. And so what oral medicines do you use for estrogen?
So I mean, most doctors will only give transdermal estradiol these days because it's the safest form of estrogen. And that is totally true. There's no increase of blood clot risk when you take a transdermal through the skin, whether it's a patch or a cream or a gel. It doesn't increase blood clot risk, which is great. The problem is we don't have any data yet that transdermal estradiol reduces cardiovascular disease the same way that oral bioidentical estradiol does. So we have 3 studies in oral estradiol, 3 randomized controlled trials that have shown decreased plaque accumulation and decreased cardiovascular disease and decreased mortality rates with oral estradiol. Oral estradiol does increase your blood clot risk slightly, probably, not as much as synthetic and not as much as birth control pills for sure, but a little bit. So there is a little bit of a risk benefit you have to think about. But if cardiovascular disease is your concern, and like lipids as well, oral estradiol is much better at reducing your LDL, your ApoB, even your Lp(a), which is very hard to get down, and increasing HDL, much better than a transdermal estradiol, which has some effect on lipids, but not really that much.
Okay. And just on that note too, like that is the reason why, perimenopausal women, generally speaking, don't have heart attacks as much as men, is because they still have all this estrogen. Then
Right.
once you look at the data, when someone gets, past their 50s, certainly in their 60s, I think it evens out quite a bit more between men and women having heart attacks.
Yeah, exactly.
So the estrogen certainly seems to be protective. That's interesting though, and I guess a little bit disappointing that we don't have any, studies on the topical estrogen. So
Yeah.
hopefully we have some more studies, and hopefully those studies show that it's effective.
Yes, I agree.
So yeah, I guess, you kind of answered the question then when you would use oral versus topical. So, if someone is, menopausal, they need estrogen and they have an issue with, lipids and with cardiovascular disease, and they're low risk for, blood clot, it seems like, oral estrogen in that case would be a bit of a no-brainer. But for other people who, may prefer to use topicals, maybe they get side effects from oral or whatever it is, using that can be effective, but they don't get the benefit of the extra cardiovascular benefit.
Right.
So I guess that's just, something that really comes down to an individual basis, and you can't.
It does.
Really say,
And you still get all the other benefits from transdermal. So you still get the bone benefits, you still get the pelvic floor benefits, the muscle benefits. You're still getting other great benefits from transdermal. It's a very good drug. And the other thing that's complicating about this, and this is, I keep telling women this because it's very important, is that if you want to have the prevention of cardiovascular disease, which again, we can reduce cardiovascular disease by 40 to 50% if we start you on estrogen early in perimenopause. But that's the important thing. You have to start it early because, and by early,
how
it's
early
usually it's less than 6 to 10 years before menopause. But I mean, after menopause onset. So if you start menopause at age 50, the earlier the better, because once the damage is done, so once the endothelial cells, once the blood vessel lining cells become damaged, they become, you have endothelial dysfunction and eventually plaque formation. But once you have that dysfunction or even plaque, then the estrogen doesn't prevent further plaque. So if you get it early, if you get to those blood vessels early before you get the damage, then you can prevent plaque and you can prevent disease. It's called the healthy endothelium hypothesis. But once the damage is done, if you already have known cardiovascular disease, then I actually, in those patients, I usually will just do transdermal because we're not going to prevent further damage. And we've seen that in studies. Like you really do have to start early to help with the benefits in the heart.
Okay. Well, that's, important for women to know. And, another, reason to get tested earlier is because, not just for, potential symptomatic benefits, but obviously for this, dramatic reduction in overall mortality. So that study, I think you posted it recently. When did that come out?
So there's a really good review study that came out in 2023 by a guy named Hodis, that looked at the cardiovascular benefits and mortality benefits of estrogen therapy and the timing hypothesis. And so that one went through a whole bunch of other studies, mostly randomized controlled trials. I think it's 23 different randomized controlled trials, as well as 40 different observational studies, and kind of compared the data and all of that to get to those numbers. But the Danish osteoporosis study was one of the ones that was a randomized controlled trial, but did show a 40% reduction in mortality rates in women who started estrogen early, healthy women who started early.
That's a dramatic reduction, because you can't really get that almost with, I can't really think of any other drug or intervention.
There's no drug, and statins don't work as well in women as they do men. Even aspirin, even a lot of these other drugs, which have some benefits, those don't compare to the benefits of starting estrogen early.
That's incredible. Coming back to the question I had earlier, though, because a lot of people probably want to know how they should apply these topical creams. You had a little video recently. We went over 3 different tips. Maybe you can go over that and share that with us today.
Yeah, and so I use creams for estrogen and as well as testosterone. Those are both great through the skin. And a couple of things, you want to make sure that you're applying it to an area that has pretty thin skin, like maybe inner arms, forearms. You can do your stomach, but you don't want to do it somewhere that has thicker skin. You also want to make sure that you don't have a lot of hair follicles that are kind of getting in the way, especially with testosterone. If you're applying it to the same area that has a lot of hair follicles, you'll actually see an increase in darkening and, in thickness of the hair in that area. So that may not be what you want. And then you want to apply it to kind of a large surface area. So think about a dinner plate size surface area. So don't just kind of put it in one spot and just rub it in that one spot, really rub it all around. You can also apply a lot of these creams to the scrotum in men, or the vulva, the outside of the genital area in women. If you'll get better absorption that way, as long as the cream is set up for that. So that's something, if creams aren't working for you, on your arm or wherever, you may consider, changing up where you're putting them. And then rotate spots. Don't just use the same spot every time.
Okay, yeah. I remember seeing a study on topical testosterone for men, applying it to the scrotum, and it increased absorption. That seems a little bit, though, counterintuitive, just because scrotal skin is the thickest skin on the body. Is there any reason or why, you get these dramatic effects despite applying it to?
It's just really thin skin. And that's what what you want for absorption is that thin skin. And the mucous membranes are also really good at absorbing stuff quickly. So the scrotum actually works great. You have to be with testosterone. One thing about, and this is true for men and women, if you are applying testosterone through the skin, you will have an increase in DHT production versus taking an injection or doing other forms of testosterone. And that's not a bad thing necessarily, because DHT has a lot of, it's an androgen, it's stronger than testosterone, has a lot of benefits, but it can give some people more side effects. So, you kind of have to balance out. So for women, for instance, if you're taking testosterone through the skin and you're starting to have, hair loss or acne, those are kind of DHT associated side effects. So oftentimes I'll just change up and we'll try an injection, or we'll try a troche or some other way of getting it into the body.
Okay, interesting. Yeah, I'm only really familiar with topical testosterone for females. I've never, prescribed it in any other way. But interesting that there are other methods out there, especially the oral method. Is that something new? Because traditionally it's kind of been taught that anything oral is not going to be bioavailable. So, what kind of treatment are you using?
So there's 2 different options for oral testosterone in women. There's a troche, which is a sublingual. So you put it under your tongue, it gets absorbed sublingually. You're not swallowing a lot of it. That's the idea anyway. And so it's kind of bypassing the stomach and the liver that way. And that's a compounded medication. The other one that's come out in the last couple of years or year or two is testosterone unduncanate. I'm sure I'm saying that wrong. Which is, and it's actually made for men, but you can use it for women at a smaller dose, kind of off-label. That one also bypasses the liver. It doesn't, even though it is an oral pill, it is absorbed through the lymphatics and it doesn't affect the liver. So old forms of testosterone, like methyl testosterone and those forms were bad on your liver. And so they weren't good long-term. But this new testosterone unduncanate is bypasses the liver and it seems to be helpful. It has a little bit of a shorter half-life. So you're kind of getting these like ups and downs that are not, they're potentially helpful for maintaining fertility for men. It doesn't suppress FSH and LH as much as like injections. Used off-label in women at this time, but they're working on maybe making a smaller dose. They'll be a little easier for women too.
And so when should women, maybe I should back this up. So, a lot of women are very familiar with estrogen and progesterone and getting those hormones replaced. Have you ever had, some women who are already on those two hormones and they came in and, they're still feeling like they're symptomatic and then you treat them with testosterone and things get better?
Yeah, absolutely. Testosterone, in both men and women, it kind of goes down slowly. Like it's a pretty slow, starting at 25 or so, you have this kind of slow decline, which is different. In women, the estrogen and progesterone, kind of falls off a cliff at like 45 or 50. But testosterone goes down slowly, but there often is a point where you start to become symptomatic. And there aren't any FDA-approved testosterones for women. So it's always, you're always using it off-label. We're always kind of modifying, what's already out there, or we're having it compounded. But testosterone is, it's just as important in women as it is in men. We make about 1/10 as much, so the dosing is a lot different. But, all the same reasons that men would take it for better sex drive, for better motivation, for better fat building, not fat building, muscle building, fat burning, mood, all of those things that can help women.
Because I think there's a lot of women who really tremendously benefit from topical testosterone for their mood.
Yes.
It literally can lift them out of depression.
Yeah, absolutely. Yeah, it's sometimes that's the only symptom people have is their mood is kind of like blah, or they're a little depressed. They just kind of don't have like that like zest for life anymore. And it's just low testosterone and it's so easy to get back.
Yeah. And I think that it's always been a little bit of like a taboo subject, but I think it's, kind of reversing it, or maybe it's being, blowing up right now, that kind of myth that, women don't need testosterone. And I've heard Dr. Peter Attia say this, and I looked it up, and it is true that, women do make more testosterone than estrogen per day.
Right.
I think it was something like 0.3 to 0.4 milligrams of testosterone and about 0.1 to 0.2 milligrams of estrogen. So
Yeah,
it's kind of crazy
we do.
to think that women do, make more testosterone than men. Do you ever order DHEA? Is that something that you prescribe as well? Would you ever use DHEA and testosterone? And what's your approach there?
Yeah, I do. I have kind of mixed results using DHEA in women. I do use it sometimes. I think that, DHEA can be made into either estrogen or testosterone, right? It's like the precursor to those things. And so, it's available over the counter. So a lot of people will just buy like the supplement for DHEA in hopes of using that to improve testosterone. A lot of women in hopes of using DHEA to improve testosterone versus having to get a prescription. Sometimes it works. Sometimes that's helpful. And I think it's okay to try. You can, if you're premenopausal or perimenopausal, I always recommend a pretty low dose, like 10 milligrams a day is plenty for DHEA, because if you get more than that, you start to have acne and like these kind of androgen symptoms that are not super fun. If you're a little older, menopausal, then a little higher dose can be useful. I tend to use DHEA with testosterone. Like I'll use testosterone, get that. That's my primary way of increasing testosterone. But then I will look at DHEA and oftentimes increase DHEA more for like cortisol, support and other things that DHEA is good for versus, hoping it gets turned into testosterone.
Okay. So with regards to the DHEA, that's more of a cortisol thing you're saying. So if someone has, say, solid testosterone levels, but they have high cortisol levels, would you then maybe prescribe DHEA to someone like that to combat the cortisol? Is that the...
Yeah, sometimes it helps. I get kind of mixed results. Sometimes it doesn't do anything. It's cheap. It's not going to be harmful. So it's worth trying for a few months and seeing if it helps. But when you're making it, DHEA is kind of the downstream on the cholesterol pathway to cortisol. So if you're kind of stealing a lot of the precursors to make cortisol, then you may not be making as much DHEA, and you may see kind of an imbalance there. So sometimes it's worse. Or like if you have like an autoimmune disease, oftentimes those people will have pretty low DHEA levels, and supplementing in those cases with pretty high doses can be really helpful. So I think DHEA it's a little misunderstood. Like I feel like it has some benefits, but I also think it's not always as beneficial as we hope it would be.
Okay. Well, I think that, I think that's a pretty good discussion overall on hormones and perimenopause, menopause, a little bit on PMS. So maybe we'll go back and talk a little bit now about birth control. So, birth control is a very controversial issue. I've had people on the podcast before, Dr. Kyle Gillette, James Hart, like they've, talked about how, and you mentioned before that there's certain birth control pills. I think Yaz is one of them in particular, where it really drops DHT or testosterone levels or free testosterone levels. But at the same time too, people want to be sexually active and they don't want to get pregnant, right? So there's a little bit of a balance there. And so when someone is, looking for birth control from you, like what is your overall approach?
So I don't tend to treat younger women. So I'm not usually the one giving birth control. I'm usually seeing people who are more like 35, 40 and above. I think that, I definitely think that birth control has its place, and I'm glad it's an option. But I do think that there are a lot of downsides to it, and that we need to do a better job of educating patients about those downsides before we just throw it out there for every woman to take. I think there are a lot of metabolic, potentially downsides. There's certainly, low testosterone and other, and even like the low estrogen, because you're giving a synthetic estrogen. A lot of these people can have, vaginal dryness and like big pelvic floor problems and, recurrent UTIs and things like that, because they're not actually getting the estrogen that they need, and you're blocking their ability to make their own estrogen and progesterone. So I don't think, and, certainly increased blood clot risk is something that we see as well. But I just think it needs to be talked about more. And, I was on birth control for like 15 years. And it's funny, I look back at pictures of myself during those. I had no idea that it could be bad for me, right? Like I was a doctor. I didn't have time to worry about like any of that. So, but I see pictures of myself during those years, and I'm like puffy, like I'm swollen, and I look like a different person. I'm like, 20, 30 pounds heavier. And I just wonder I'm sure my lifestyle wasn't perfect. I'm sure it wasn't just the birth control, but once I got off of it, it was so much easier to lose weight, to sleep, to get healthy. So I have my personal experience with it, but I also think that it's maybe just something that people should think about before they get on it long term.
If you're okay with it, can you tell us a little bit more about your personal experience coming off it? Like, what did you really notice? What did you notice when you came off it and you found like what benefits versus, and what would you notice say was, something that you really wanted to eliminate by getting off of it?
I was on, again, when I was on it, I didn't really think, I started taking it like, 18 or 19. And I took it all the way through until like 2 weeks before I got married, which is I think I was like almost 30. So I was on it for more than 10 years. But I was also, I was super busy during that time. I was doing my medical school residency. So I really just, I was happy to have it. But I stopped taking it 2 weeks before I got married. And I got pregnant 2 weeks later. So I got pregnant with twins, by the way, 2 weeks later. Did not, but I also I looked at, I started noticing that I lost weight. Not tons, but like several pounds of weight. And I look at pictures from, between college and all of my medical training, all those 10 years that I was on it. And I was just like swollen and puffy and just less healthy looking. I did notice when I got off of it that my libido changed. Like I definitely had more of a sex drive when I got off of it. And that makes sense, right? Like we know that that's a thing. Those are the main things. Just it was a lot easier to lose weight, and that my sex drive was a lot better when I got off of it.
Did you feel a little bit better mentally, like through potentially increased testosterone, like more motivation or anything like that?
Uh,
Or not so much?
I think it's hard to say because my lifestyle had changed. I'd gotten out of residency. I was finally working at a real job. So it's kind of hard to say if that, I think I did feel better, but I don't know if it was from that or just from my life.
Okay. Well, really appreciate you sharing that. I know that was a little bit personal, so I really
Oh, no
appreciate
problem.
you sharing that. So I want to ask you too, like, so I'm a family doc, and I work in a walk-in clinic, so I do have a few more sort of like just basic family medicine questions that maybe some people want to know about. So, I can't tell you how many people I see, how many women come in with recurring yeast infections. They tell me that
Mm.
I'm always going to get over the counter fluconazole. I'm always getting Canestin. So why is this happening to so many women?
Well, one reason is if you're on birth control, it makes total sense because because of the loss of estrogen, again, you're not really making your own estrogen, and the pelvic floor is not benefiting from the synthetic estrogen that's in birth control like you'd think it would. So you're messing with the flora of the vagina. You're messing with the normal microbiome. And so you're going to be at increasing risk for yeast infections, bacterial infections, which we see in menopausal women, of course, but you can also see that in just young women who are on birth control because of that imbalance that you're seeing. And in those cases, by the way, I highly recommend taking a vaginal estradiol, like a low-dose vaginal estradiol. I don't care if you're 25. If you're having those symptoms over and over again and you're on birth control, a low-dose vaginal estradiol won't mess anything up in the rest of your body, but it will help to normalize the vaginal microbiome and help those tissues stay healthy.
So you can stay on the birth control and take extra estradiol, and then that will assist with those symptoms of the
Yeah.
recurrent yeast infections.
In
Okay.
the low dose estradiol, the vaginal estradiol I'm talking about, it's like 0.01%. So it's very low dose. So it's staying just in the pelvic floor. So it's not going system wide. You're not going to have other estrogen effects from it. But it's helping with the recurring infections, with vaginal dryness, with, maybe pain with intercourse, some of the things that we see that can happen usually later on, but can happen in young women as well. So I'm a huge fan of low-dose vaginal estradiol. I think every woman over age 45 should be on it, but even some younger women as well.
And that's safe to be taken throughout the entire cycle, not just
Yeah.
on days 15 to 25.
And it's safe for breast cancer survivors. It's safe for athletes. You think about these athletes, these women who, don't have cycles because they're super thin and they're working out a lot. At the minimum, a low-dose vaginal estradiol is great because they don't have enough estrogen in their body. And so certainly eventually you want to get them cycling again because their bones are getting weaker. You're going to get a lot of long-term downsides of not having actual cycles. But in the short term, if you need to stay at that level, a vaginal estrogen is great.
Okay. What about the vaginal suppository probiotics? Would those be helpful for someone who's experiencing some of these symptoms? Is that something that you're familiar with?
Data is still out. I mean, I think we don't have strong data on those yet. I think, it's worth trying. I don't think it's a bad idea, but we don't have like tons and tons of studies. Or at least I haven't seen good studies yet.
Yeah. So basically it seems like the estradiol is definitely going to work. So why not use that if you're, super opposed to it for whatever reason and you want to use the vaginal suppository probiotics, you can do that. And, if that works for you, great, keep doing it. But if not, just know that there's no real data, confirming that it's going to be super beneficial. So
Yeah.
it's a little bit of like a shot in the dark.
Yeah. And definitely don't put anything else up there. Right. I mean, this, I know, but like, don't douche, don't put enema, like just don't put other things up there that aren't supposed to go up there.
Okay. I think that's definitely needed to be said because you never know what
Right.
people are doing. So,
Yeah.
definitely want to remove the cause, right? So in addition to, since we're talking about vaginal flora, again, the things that, come up again in my practice in the office every day. So people will complain that, sometimes when they're having particularly like oral sex, but sometimes even just, regular intercourse, but particularly oral sex, a lot of girls will complain that that's when their vaginal flora, gets messed up. That's when they get yeast infections. And they'll, indicate to me like, it's not my boyfriend, it's not my husband. I make sure he's got great oral hygiene and that kind of thing. But for whatever reason, this is still happening. And so, what is your approach if you've seen someone like that?
Yeah, it can be tricky. Some women just have reactions to certain partners. Like even like if they have more than one partner might cause problems with recurring like infections, and other partners don't. Which I don't know. I don't think that we understand exactly why. Or certain condoms can do it. Or there's something about some people that just they seem to be irritating to the vaginal flora or the vulva. I don't know why, honestly. I'm not really sure what the reason for that is. I think that, trying different things, maybe trying different lubricants or different, like just making sure that you're not irritating, like making sure that you're not causing more irritation from whatever, like from the rubbing or whatever that's going to then make the other start, make it more irritating is important as well. But I don't know why women react to some people or some saliva or, why is that a problem? I have no idea.
Okay. Well, hopefully we can figure it out one day for the women who are struggling with that.
It's a weird study to do, I think, but
it's a weird one, but I think a lot of women would appreciate it because of the volume of people I see, because where I work in a walk-in clinic, I can see like 200 to 300 people a week, like easy, like all the time. And so, I'm going to get a lot of, gynecological, cases like this that come up, right? So moving on to another subject here, but still, talking about perimenopause and menopause. I know that you recently did a video too on microplastics. I wish I had listened to the Huberman podcast, and I just haven't had a chance to do it yet. But is this something that you discuss with your patients? Is it something that you're, worried about? And what are the things that people should be looking out for, and how can they reduce microplastics?
I am worried. It's one of those subjects that makes me, it's such a, like, they're so ubiquitous, right? Like they're everywhere, and it's so hard to get away from them. My brother is a hydrologist. So he's like, he studies water. And so like a decade ago, he started talking about these microplastics. He was like, sampling these rivers in Wyoming and, coming back and saying, hey, Amy, the things you're using to exfoliate your skin, they're full of microplastics. Stop doing that. I'm seeing them in the rivers. Hey, Amy, he was coming to me with telling me about all these scary things. And I was just like, see, you're just bitter. You're silly. But I think that's a real problem, certainly. We're seeing them, as you know, we're seeing them now in testes. We're seeing them in ovaries. We're seeing them in blood vessel walls. And
in the brain too, right?
In the brain. And we know that they're biologically active. And there's two problems with them. One problem is that they're just kind of mucking up the mechanisms of they're actually physically just stuck in these different organs, which is obviously not a great thing. And then the other problem is they're associated strongly with multiple different endocrine disrupting chemicals. And so your BPA, your phthalates, a lot of these other chemicals that are associated with microplastics are also then getting released into the body and making, we're kind of wreaking havoc on the different hormonal systems, the sex hormones, the thyroid, hormones. So I think it's a twofold problem. And, I don't think there's a really great solution right now, except to just do your best to avoid plastic food containers, plastic straws, plastic bottles, anything that's plastic. If you have another option, glass preferably, or aluminum or something, then choose that option. Never microwave plastic. My kids still do this sometimes, and I'm always yelling at them. And then eventually, I'm hopeful that eventually we'll have some kind of way to filter out these microplastics efficiently for, the greater population, because I think it is going to continue to get worse.
Yeah. I've, tried to do my best with it. Like I, take my water with me today to work every day. And, we have a system where we, can remove the fluoride from our water as well. So, I take that to work with me every day. And then I only use glass. I don't use any plastic Tupperware. But those are things that are going to reduce and will mitigate my risk, but I'm well aware that it's never going to be, 100%. And again, with like the fluoride thing, like that's what I do at home. But if I go out to a restaurant, I'm not going to not drink the water if someone, pours it there for me. But I know that by drinking that at home, by, drinking it at work, it's going to be 80% or so of the water that I consume, or even more. Right. So I think it's good for people to be aware of, and for people to make reductionist habits, but it's also like don't go too crazy with it because, like for example, I wear a lot of Lululemon. People are saying now, okay, this Lululemon's gonna like, I can't change my whole wardrobe,
No, I agree. I agree.
like I can't, I just can't do it. So,
Yeah.
I'm happy with just minimizing, but not going like crazy.
Yeah. That's kind of my approach to like health and wellness in general. Like I know all the bad things. I do my best to avoid the ones I can, but I don't believe in going crazy. I think that will cause me more anxiety than anything. So I try to kind of live in the middle somewhere.
Yeah, same here with me too. Like, I don't touch alcohol during the week, but for Jake Paul and Mike Tyson tomorrow night,
Exactly.
I'm probably gonna have two doubles. That's kind of my thing.
That's how I am.
Two doubles gives me like a really solid head change, but I don't need to. I'm still okay the next day.
Yeah. Yeah.
So
that's exactly how I am. I'll have a couple of drinks in the weekend, maybe, and then the week I just do without usually.
And it makes my life better. You know what I mean? Like, I enjoy it, and I'm with good friends. And
the social part is, I think the social part, and I don't think that everyone has to drink by any means. I think it is a toxin for sure. It is bad for 100%. You. But I do think that there's a nice like social thing that happens sometimes that some of us enjoy.
Yeah, and it's also too like you're looking forward to something. Like, sure, I'm looking forward to my friends, and I'm looking forward to the fight itself and that kind of thing. Yeah. But it's something that you can look forward to, which I think is important.
Agreed.
So I only know I got you for a few more minutes, and it's a subject we won't be able to get into too much, unfortunately. So maybe I have to have you back on. I'm interested in having your brother on too. Actually, he seems like he'd be a great guest. But in terms of peptides, like this thing, I kind of mentioned this off air before the show. It seems like it's kind of been like a bro industry. And like, I fully admit, all the guests I've had on who've talked about peptides in this show have mostly been males, mostly for the most part, I think. But in terms of peptides and how females can use them, like, is there any like ones that are specifically for females, or how, like, what is your overall approach for females using peptides?
Yeah, I think that I'm trying to think, I think there's not really any that are just for females that I use. PT141, which now is a FDA approved drug, Belisi, it's approved for women for hypoactive sexual disorder. And that one, of course, is useful for men and women, though. So PT141 is a great one that was primarily used in women, but we use for both. I use a lot of the GLP-1s, which I think everyone does at this point. I use a lot of, I love BPC 157 for men and women. I think it has a lot of benefits, although we can't prescribe that currently as an injectable because of the FDA. I'm a fan of the growth hormone secretagogues as well, like, CJC, 1295, ipamorelin, testosterone, anything to increase growth hormone. I think for women especially, building muscle in the post 40-year-old woman is so important. So anything that I can give them that's going to be anabolic, testosterone, of course, growth hormone potentially, and then the growth hormone peptides can be really helpful in that population as well. And I love GHK copper for skin and hair topically, but I also like it as an injectable and wish I could give it. But it's also on the list of things I can give.
Nice. So for the GHQ copper, you said you use that mostly topical, just on the face, or to prevent like wrinkles and that kind of thing?
Yeah, face and hair. So it is, you can use it, it's found in a number of creams. You can look at like some of the face creams that's out there, or you can just get it from a compounding pharmacy. I'll oftentimes combine, for women, I'll combine GHK copper with estradiol, because you can actually put low dose estradiol on your skin too. And especially in the post 40-year-old woman, that's also great for slowing skin aging. So I'll put those two together with maybe some hyaluronic acid, and I'll compounding them together into a face cream, and it is fantastic. And then I also like GHK copper for hair restoration. So we use that in men and women. It's great with zinc thymulin, as well as some other peptides for hair restoration.
And so for like a great face cream, like the hyaluronic acid, the estradiol, and then the GHQ copper are sort of your go-tos. Cool.
Yeah, that's a fantastic one. I love that cream. That's only for, the 40-plus-year-old woman. The younger woman doesn't need any more estrogen in her face. But we can use the low dose estrogen on the face, just like we can in the vagina, and it just stays in that one space. But it reduces, it helps with hydration and can reduce wrinkles and effects of skin aging.
Okay. I know that do you have to go, or can I ask you maybe one more question?
No, it's
Still
fine.
with
We can do
you.
one more.
Sure. Okay, sure. So, we just had a recent, election. Some people are upset about it. Some people are not upset about it. Obviously RFK Jr. is, kind of come to the forefront in what he wants to do in America in terms of trying to, turn things around with this Maha movement. How do you see this affecting you, affecting your practice, affecting your patients, and what are your overall thoughts, if you're okay with answering that?
Yeah. I, as a women's health doctor, I have to say I was not for, I was not for President Trump. I think that he is not for women's health in general. I think that there are probably some benefits to the things he wants to do, but I don't think that that women's health was really one of the things that he is most known for. So wasn't a super fan, but at this point, I'm ready to be excited about whatever the next phase is. So if RFK can help us, and I do stem cell medicine, I do peptides, I do a lot of these kind of like off to the side kind of therapies and treatments. And I would love for those things to become more widely available, to have have the FDA or whatever agencies in charge and not be quite as hostile towards them. So I'm optimistic and I'm hopeful, even though it wasn't my first choice.
Got ya. Well, I certainly hope that, things work out for women and that women, get what they want, and that this doesn't affect them negatively in any way, shape, or form. And, hopefully, RFK has just as much of an initiative on that as he does with some of the other things that he wants to do as well. And then also too, my sort of thoughts on that is like, I think it's amazing, that he wants to make all these changes, but at the same time too, like the changes are like small levers. Like I talked to you, and we just talked about, how I remove like, fluoride from my water and that kind of thing. Like, that's a very, very, very small lever in terms of my overall health and what I do.
Right.
Like my sleep, my training, my diet, nutrition, getting sunlight, all these things are like, those are the major, major things. Right. And so even though I think that what he's doing is very noble in some ways, and I think that he genuinely as a person, even if he's wrong on certain subjects, I think that he is genuinely trying to make a difference, and he does want the best for people. And that's what I do really like about him. And the same thing too with like, the seed oil thing. Like I don't really like seed oil is never really part of my diet, but like from all the data and research I've seen, like I don't think that necessarily like replacing seed oils with beef tallow is going to make a dramatic difference
Right.
overall. I'm not saying it's going to do nothing. I'm not saying that, but it's just like, it's a very, very small lever overall.
Right.
And
I
I
agree.
think that people need to realize that, it comes down to personal responsibility and taking care of your own health. Like whoever's in power should not affect your health.
Right.
Like you're in charge of your health. You're in charge of, your body and what you should do. Again, with the Women's Health Initiative, I understand that that's something that maybe is, maybe they're not in charge of, and why you guys would be upset about that. So that's a little bit of a different story. But some of these other levers that I'm talking about, like the fluoride and the seed oils. And again, I don't want to be a hypocrite. I try not to consume fluoride, and, seed oils were just never really part of my diet, in general. But I am optimistic, and I really hope that, we can all certainly like, come together. And, I've had, I think, Ashley G. Winter, she's been on, the show before,
Yeah.
Dr. Winter. And, she certainly, doesn't like Trump at all, but I think she's a wonderful person. We had a wonderful conversation.
Yeah, she's great.
And I look out for her tweets all the time because I still learn from her, so hopefully we can all, just come together and hopefully things get better for everyone in America and in Canada. I'm in Canada. So
Yes. No, I agree. I'm ready for the next phase. I hope it's a good one.
that's awesome. Okay. So we're all wrapped up here now. Is there anything else you want to share, and where can people find your work online?
So I'm pretty active on Instagram, Dr. Amy B. Killen. I'm a little bit active on Twitter, which is Killen MD. I'm also on Facebook and YouTube and all those places. And then I have a couple different companies. I have a female-focused supplement company called Hopbox. That's where the hop comes up here. And that's at hopbox.life. It's a longevity female company. And then I also have a longevity clinic that we just launched in Austin, which is called Humanaut, like astronaut with an AUT. So if you are
Cool
in
name.
Austin or Texas, we're expanding to Dallas and Florida in the next few months. So that's also coming up pretty soon if you're interested.
Awesome. Well, congrats on that. And I wish you all the best on the expansion of your clinics.
Thank you so much.
So thanks again so much for coming on. You shared a bunch of different information that I think a lot of people are, really going to benefit from, and you answered all my questions. So really appreciate that. Thank you so much for coming on.
Thank
And
you.
again, thank you so much everyone for listening. And as always, I'll be back with another episode soon.